but there actually has been no protection for us to be able to tit for tat with the agency. So we were like, why are we charging for hiring of people anyway, as if there's some form of commodity? We really ought to eliminate this practice altogether. And so basically agencies were incentivizing with recruitment bonuses their employees that come in and work alongside ours to recruit our employees away. And there was a cost to us if we wanted to get them back. So it was a buying and selling of people essentially in the labor market, which is completely inequitable. So anyway, it passed the House, and I really hope that it's going to continue on without amendment, but we'll see. It'll just prevent them from charging the facility. We're talking anywhere from a $1,500 charge for the hire on all the way up to a third of their annual salary. I mean, it could be really crazy in some of these cases. And it just, if it keeps you from hiring someone as a permanent staff person, that's not really fair to the individual in terms of employment choice either. I did submit a couple of grants on behalf of our membership, and I'm awaiting review over the next 90 days. Wanted you to be aware this is out there. Trauma-informed care is required for implementation as part of pay for performance, and a lot of our folks don't have an expert in-house. So we are offering to, through this grant, hopefully, pay for free certification through the ACA APAC course. It's an 8-module course. It gives them CE credits and NAD credits if they complete it as a National Association of Administrators. And then that would be available to half the buildings in the state. We're not anticipating that more than that would probably participate. Participation's tough to get. And then the other one is an employee communication software to work on employee retention. And they did this in Utah. It worked so well that they actually are trying to re-up it this year with the push from the health department itself, saying that it really helped. So the idea is real-time employee feedback and ways to track the timeliness of response to employee concerns. And then this is our upcoming education and events. Again, you can peruse this of your own accord. We did change the February 21st course for social services. It is now moved all the way to May 2nd due to some speaker conflicts. So there you have it. Thank you so much.
Oh, thank you, Jenny. Thanks for all these great, timely, and relevant updates for our communities. Are there questions for Jenny? I'll be sure to send out the slides so that we all have access to this information. Thank you so much.
We'll get those right over to you, saying thank you.
Appreciate it. Chad, thanks for joining us today. Can you present our updates from CDPHE?
You bet. I didn't make a PowerPoint, so maybe I'll just go ahead and sing my presentation.
You are certainly welcome to.
Well, I reconsidered because of the No Surprises Act. I figured I probably should not do that, right? So, and not to delay how much longer. Jenny did cover a few of the items I wanted to talk about. So great information, Jenny. Just want to let you know that a number of our guidance documents have had technical changes and some updates being done. We're getting ready to roll out a new version of Chapter 5, so that pertains to complaints from the federal side, Chapter 5. And we have some timelines that we'll need to come in line with. We spent a bit of time here recently, over the last so many months, working on our process to address facility reported incidents. We're going to need to triage those within the program, and so we put out a beta group, I guess, to see what that's going to look like. We anticipate that may mean there could be an increase, however so slight or large, in the number of on-site complaint follow-up that we do that are related to facility reported incidents or your occurrences. Again, technical changes for the State Operations Manual, Part PP, and again, Chapter 5, the federal Chapter 5. Were rolled out 3 changes to Chapter 7, or technical changes to Chapter 7. It looks like will be rolled out 228, and Chapter 7 has to do with enforcement. As Jenny had mentioned, CMS is starting to complete MDS audits to look at schizophrenia coding, and we'll adjust star rating for facilities with inaccurate coding. Kind of in response to that, there's been a lot of conversation going around about creating psychotropic stewardship programs, and beginning with the questions when and why. So I'll just kind of throw that out there, and we'll segue in a minute to something I think is very much related. But in terms of survey or review that is related to this, we're going to be we're being asked to look at a number of areas. FTAG 641, accuracy of assessment; 642, coordination and certification of assessments; 658, services provided to meet professional standards; 758, which is to be free from unnecessary psychotropic medication use and PRN use; and 841 is the responsibilities of the medical director. So when we go out on site and we're completing our inspections, the direction is that we pay particular attention to those areas as they relate to the schizophrenic coding and the use of psychotropic medications. And that kind of segues to my last thing that I wanted to share with you, and that is really an emphasis that's being placed on the quality assurance performance improvement process. And as it relates to all of the members, that it's an active process, and certainly, psychotropic medication review is or can be a part of that, in addition to some of those other areas that have a high likelihood of creating adverse outcomes in the presence of deficient practice. So looking at those areas, but looking at how the facility is identifying concerns for themselves, what plans are being put into place. And as I like to talk to facilities about, is that, it's really a situation where, if you have 7 failures, you have 8 attempts, that we're continually looking for something to address the concerns that are being identified. The facilities in good faith have identified those concerns for themselves and are putting plans into action to address those concerns. Again, the QA performance improvement process and the involvement of all team members is going to be, paramount to addressing those areas. So that's the report I have for you today. And since I didn't sing, I think we'll all probably have a good afternoon.
Thank you so much, Chad. I think as we all dig deeper into that process of antipsychotics use and identifying the diagnoses, we might come up with more questions for you. There is a question in the chat box. I wonder if you could repeat those tags that you thought might be affected or associated with this,
Absolutely.
with this antipsychotics.
Absolutely. So that is 641, which is the accuracy of the assessment. 642 is coordination and certification of the assessment. And so that's referring to the MDS. 658 is services are provided, the services provided meet professional standards. 758 is the freedom from unnecessary psychotropic medication use. And 841 is the responsibilities of the medical director.
Great, thank you.
Thank you.
Great. Appreciate that structure and construct. Great. Well, if there are other questions for Chad or Jenny, please feel free to put them in the chat box. And we will go on to our last presenter of today, Dr. Lauren Biehle, PharmD, who is the Antimicrobial Stewardship Director for CDPHE, is here to talk to us about stewardship strategies for interpretation of novel urinary diagnostics.
Yeah, thank you, Singh. Hi, everyone. My name is Lauren Biehle, and as she mentioned, I am the Antimicrobial Stewardship Pharmacy Lead for CDPHE. So we were asked to speak today about some newer diagnostics that you may be seeing. I think we're used to seeing things like culture and sensitivities that we've been seeing for many years, but now we're seeing more things like rapid diagnostics, like PCRs and others. So wanted to talk through what those results look like, provide some examples, and also some strategies for evaluating them to promote both antimicrobial and diagnostic stewardship. I really like interaction as a speaker, so feel free to unmute or put questions in the chat, but happy to take any questions as they come up. So today our objectives are to talk about methods for evaluating urinary diagnostics in the nursing home setting, comparing rapid diagnostics, specifically PCR, polymerase chain reaction, which is the most common one, to traditional culture and sensitivity, and then again applying antimicrobial and diagnostic stewardship to the nursing home setting. So I'd like to open it up to all of you. Pretend that you receive a call about an 86-year-old resident who has this result from a urine sample. You're told the patient has 4 organisms detected: Enterococcus faecalis, Proteus mirabilis, Pseudomonas aeruginosa, and Staph aureus. So I'll just open it up for a minute. Does anyone want to mention what their next steps would be?
Other than throw it away?
Great, that's an option. Absolutely, Dr. Gum. Yes. Any others?
And how did we determine it was a positive result? What were the reasons for checking the urine?
Great, exactly, absolutely. Oh, and it looks like there's some in the chat too. Symptoms, thank you, absolutely. I think these are all really, really great examples. So we know that up to 79% of nursing home residents receive antibiotics every year, and up to 3/4 of those may be inappropriate, with the greatest contributor being asymptomatic bacteria, which we'll talk a lot about today. And segueing from our previous speakers about antipsychotics, antibiotics do exhibit the second highest rate of adverse drug events after antipsychotics. We know that being a resident of a long-term care setting is a risk factor for multi-drug resistant organisms and C. diff. And if you have high rates of antibiotic use in a facility, it's actually associated with increased rates of adverse events among all facility residents and not just those receiving antibiotics. So for these reasons, CDC and CMS have identified nursing homes as priority areas for stewardship. So we wanted to come up with, again, strategies that we could evaluate any urinary diagnostics or new diagnostics. We now know there are over 3,000 clinical lab diagnostics that can be ordered for nursing home residents. And so really important to have ways to evaluate each one as they come up. So these rights are based on the rights of diagnostic stewardship. Step 1, right patient. Step 2, right time. Step 3, right test. Step 4, right bug. And step 5, if needed, right drug. And I'll go into each of these in more detail. So the right patient would be, just like was mentioned, what is the indication for testing? Does the patient have any localized urinary symptoms? As far as right time, is it the right time to test? Does the patient meet Loeb criteria? What's the pre-test probability that this is going to be positive? For right test, what's the sensitivity and specificity of this test? As we're going to talk about, PCR is much more sensitive, so we have to know that context going into these results. Is there any quantitative data available that can help us? And as Dr. Gom mentioned, if it's polymicrobial, should we recollect this test and start over? The right bug, so if you're getting multiple or polymicrobial results, is the organism a common urinary pathogen, or does this result actually indicate colonization? And then finally, if you decide treatment is needed, going back to antimicrobial stewardship principles with, if it's a symptomatic UTI, using things like facility treatment guidelines, antibiogram data to optimize the right drug, right dose, and right duration. So let's go into each of these individually. The first step with right patient, what's the indication for testing, and does the patient have localized urinary symptoms? So this is from the CMDA from 2020, their guidelines on diagnosis and treatment of urinary tract infections. I've just highlighted the asymptomatic bacteria and simple cystitis, but for asymptomatic bacteria, having that at least 100,000 colony count per ml of bacteria and no signs and symptoms localized to the genitourinary tract, they recommend no antibiotics. And then for simple cystitis, as well as catheter-associated UTI, you see similar microbiology results, but also the addition of localized symptoms. And so similar to the Loeb criteria, which we'll talk about, these may be things like dysuria, suprapubic tenderness, frequency, urgency, and things like that. And then they do have their treatment recommendations in the third column as well. So I did want to take a quick minute to talk about asymptomatic bacteriuria. So this is again bacteria recovered from a urine sample in a person without localized urinary tract signs or symptoms. AMDA does not recommend screening for or treating asymptomatic bacteria in nursing home residents. It's really interesting because up to 90% of nursing home residents will have pyuria at any time. So the presence of white blood cells in the urine. And there's bacteriuria in 50% of female residents and 40% of male residents. So really, by screening for an asymptomatic bacteriuria, the culture could be positive at any time and not actually represent an infection going on. The only 2 times that IDSA does recommend treating asymptomatic bacteriuria is in pregnancy or immediately prior to a urologic procedure. This is often things like a TURP of the prostate or something like that, where we wouldn't want bacteria present in the setting of that procedure. But otherwise, it is not recommended to treat asymptomatic bacteria. Having asymptomatic bacteria does not increase morbidity and mortality, but it can lead to unnecessary antibiotic exposure and adverse effects. So ASB does not equal UTI. Next, we can go into right time. So is it the right time to test this patient? Do they meet lobe criteria? And what's the pretest probability of our results? So I think we're all familiar with the lobe criteria developed in 2001, the minimum criteria for initiating antibiotics in long-term care residents. So I just wanted to point out that in both settings, with or without an indwelling catheter, the focus is on local signs and symptoms. So dysuria, urgency, frequency, suprapubic pain, costovertebral tenderness, things of that nature. We do have a suspected UTI action tool on our website. And so this goes through similar to the lobe criteria. It's available for care team staff to walk through and see, does the resident have new or worsening signs or symptoms that meet one of the 3 criteria for a suspected UTI? So you can go to our antimicrobial stewardship website, which is listed here. And if you click on CDPHE toolkits for long-term care facilities. And then for the right test. So this is when we're going to go into some of those examples. So what's the sensitivity and specificity of this test? What quantitative data is available? And if our result is polymicrobial, should the test be recollected? Is there a question?
I think there was some background noise.
Oh, no
but there's
problem.
a comment in the chat box from Dr. Gom, which
Yes.
just remind us.
Dr. Gom, I absolutely agree. Yes, I definitely agree. Fluoroquinolones should be last line, especially for simple cystitis. I really like that statement at the end. So reserving fluoroquinolones for those who have no alternatives. I really like that wording from the FDA, and I completely agree with you. So I'm going to take, thank you so much. Thanks. So I'm going to take just a second to talk about sensitivity and specificity. So sensitivity being those who test positive who have the disease, and specificity being those who test negative and do not have the disease. So we know that if there's a higher prevalence of disease within a population, then there's a higher positive predictive value. And the higher sensitivity of a test usually leads to a higher risk of false positives, which in this setting, we're going to be talking about rapid diagnostics like PCR that are much more sensitive than a urine culture. And so with all of this, we really want to make sure that we're interpreting our test results in the context of probability that an infection is present, which would be those who have localized signs and symptoms of infection. Talking about diagnostics for UTI, I took this from one journal article, but just narrowed it down to dipstick, urine culture, and PCR. So I'm going to focus on the bottom 2 columns of urine culture and PCR. So with urine culture, it's done by Auger or automated systems like Vitek or Microscan. With PCR, it's a completely different system where we're targeting DNA and amplifying it. So very different. Cultures are FDA approved, while PCR is not FDA approved. With urine culture, we can identify bacteria and develop a susceptibility panel, which we're all pretty used to seeing. With PCR, we can identify bacteria, but there will not be susceptibilities. Instead, they just test antibiotics for resistance genes. They test the bacteria, for resistance genes to antibiotics. Some pros of the urine culture. In this article in particular, they consider it the gold standard. The pros for the PCR is that it is very rapid, which we'll talk about how much faster it is, and it is highly sensitive. So cons of the urine culture, of course, it does take a longer time to result, and it does not distinguish asymptomatic bacteria from infection. With PCR, it does provide resistance genes, but does not provide susceptibilities. Similar to the culture, it does not distinguish asymptomatic bacteria from infection, and it may provide polymicrobial results. So again, specific to the PCR, which is the main one we're going to talk about and the main examples that we have, it's going to utilize multiple primers to detect several targets with high sensitivity, and it identifies pathogens over 40 hours faster than a culture in sensitivity. The cons are that it is not seen to completely replace the urine culture. It also, due to its sensitivity, has many more polymicrobial results. So about 29% of the time, you'll get polymicrobial results with PCR versus 7% with culture and sensitivity. As you'll see, we have less quantitative data to help us distinguish colonization versus infection. So with a urine culture, you may have colony count. With some of the PCRs, you have less data to go on. Again, there's no susceptibilities, just results of resistance genes. It does tend to be more expensive. And because it's not FDA approved, there is not a standardization or consistency about formatting of the report. So you do have to interpret each one based on the manufacturer. So let's just talk about an example. So this is an example from the patient case that I opened with. So I have this broken down in another slide, but on the left, the top left, you can see the organisms that were grown. So these include things like Enterococcus faecalis, Proteus, Pseudomonas, and Staph. Below that, you can see the resistance genes that were tested. So this is not susceptibility, but it was just these particular resistance genes were tested. And then on the right, the manufacturer will sometimes give a recommendation for an antibiotic. So in this case, they're recommending fosfomycin and linezolid. So these are both very broad spectrum. And often these will be broad spectrum as the organization or the manufacturer is trying to cover for all the possible pathogens that are listed. I'll pause here. Are there any questions so far? Okay. So next, we have this polymicrobial result. Let's try to see if it makes sense. Is this organism a common urinary pathogen? And does this result, in fact, indicate colonization? So when we look at this, we see E. faecalis, Proteus, Pseudomonas, and Staph. Unfortunately, we don't have quantitative data to tell us if one is more common than the other. Enterococcus faecalis may be a contaminant, as it often isn't extremely pathogenic. Proteus may be a pathogen. Pseudomonas could be a pathogen. And if Staph aureus truly is a pathogen, we'll likely want to be looking for another source of Staph as well. So in this type of report, it does not give us a lot of quantitative data to go on. So I'll show you an example of one that does have a little bit more quantitative data to it. So when we're talking about rapid diagnostic results, I think it is important to see what kind of quantitative information we have, which resistance genes were tested since we don't have sensitivities. Do these results indicate colonization or infection? We really want to try to treat the most likely causative organism rather than all pathogens. And keeping in mind that the antibiotic in the recommendations in the report are likely to be overly broad in order to treat all pathogens. And then finally, like we kind of talked about from the beginning, if you still have a high suspicion for infection and your result comes back as polymicrobial, you want to be thinking, should this test be recollected, similar to what you would do with a mixed flora or dirty catch result from a culture? Yes, Leslie, I agree. I think one of the challenges is that it sounds like some of facilities are going to the lab or going to these types of labs. So while I think culture still provides the most quantitative information and it is what's recommended in the guidelines, when you do come across these, I think, you know, having some framework to kind of work through them because they do look so different from our culture and sensitivity reports. But I agree, the sensitivity of these could lead to overly broad prescribing for sure. So this is another example. So in this one, this is just how a different one looks. So For this one, I have it in a red box here. You have high, moderate, and low. So high, you can read their kind of glossary down here. Likely active infection. There were none detected in the high category. For moderate, maybe choose to treat. Again, none detected. So really for this low, they recommend to monitor for infection. And that's what grew Enterococcus, Prevotella, and Serratia, none of which are very common pathogenic organisms. So in this case, we do have a little bit of quantitative data that could guide us and show us that this is probably colonization and monitoring for infection. But again, we want to think back to why was this taken in the first place, or why was this done, this PCR sent off in the first place. I also just wanted to show that this is what the resistance gene panel will show. And so it kind of looks like a sensitivity report, but in reality, it's just showing that the only antibiotic that was tested to be resistant was trimethoprim. So you could use any of these. But again, I would want to think about, does this make sense as a causative pathogen? And given the low quantity of bacteria, this is probably just colonization. All right, and then last thing, and then I will be sure to address the questions in the chat. So if you decide to treat, looking into that right drug, so utilizing facility treatment guidelines and to optimize your right drug, right dose, and right duration. This is straight from the CMDA. So it has its treatment guidelines for no antibiotics for asymptomatic bacteria, antibiotic recommendations for cystitis, catheter-associated UTI, and pyelonephritis. As Dr. Gaughan mentioned, fluoroquinolones are last on the list and should not be considered first line, particularly for simple cystitis. If we decide not to treat the UTI, AMDA recommends increased hydration, and AHRQ does offer these active monitoring orders. So encouraging a certain ounces of liquid intake, recording fluid intake, monitoring vital signs, requesting notification if symptoms worsen, and consulting a pharmacist are all active monitoring options for asymptomatic bacteriuria. And so lastly, I just wanted to close with our core elements of stewardship and how those apply to UTIs in the nursing home setting. So things like for leadership, appropriate prioritization and communication. For accountability, those facility-specific policies and procedures. Your pharmacy expertise to help develop facility-specific treatment guidelines and antibiograms. Communication and establishing orders for action, tracking and reporting, and then education on this topic as well. And so I just want to close with this example as well. So I want you guys to, this is a real example again, de-identified of a skin PCR report. So what you can, how to orient you, I know it's a little bit grainy, but on the first column of where it says bacterial load, this report is showing 8 different organisms on this skin PCR. And so I think we can use the same framework, even though it's not a urine PCR, to evaluate this. So let's see if we still think the patient is infected, what kind of quantitative data do we have? That's going to be in the second column that says DNA copies. And so what we see is that the only 2 that are even low are Pseudomonas and Strep. The others are all just next generation sequencing, meaning that they're detected, but not in any even quantifiable amount as low. So I think immediately you could consider these bottom ones to all be colonization. Then you could consider Pseudomonas and Strep. Pseudomonas is often a colonizer. So likely if this person does have an infection, it's due to Strep, that second organism listed there. And what you can see on the right are all the different antibiotics tested by the resistance genes. And so as an example of why it's so important to critically evaluate this to see if it makes sense, the only option you have to treat both Pseudomonas and Strep on this report is a carbapenem, which is really a huge big gun antibiotic if we're just treating a Strep skin infection. So again, I think this is where your treatment guidelines can come into play, and really critically evaluating this to not try to treat all 8 organisms that the PCR comes back with, but to take a look at using those 5 steps to evaluate if it makes sense for this patient. So really quick summary, the 5 steps that we recommend are the right patient, right time, right test, right bug, and right drug if needed. utilizing lobe criteria and local urinary symptoms to treat infection, not treating colonization or asymptomatic bacteria. Any quantitative data that you have on the report can be helpful when you're trying to narrow down the causative pathogen. Incorporating diagnostic stewardship, and as always for antimicrobial stewardship, incorporating action tracking and reporting with individual audit and feedback. So that concludes my presentation. I'm going to take a look at the chat. Yes, so as far as how broadly they're being used, I spoke to one manufacturer that had 10 facilities in the Denver metro area. So initially they were out of the states, but now they are becoming more common in the metro area. They are certainly more expensive than a urine culture, that is for sure. The scale, absolutely. So that's another thing, though I do mention the quantitative data and using what's available, it does not correlate with like our typical colony count that we're used to. It's going to be things like DNA copies or amplification from the manufacturer. And then I have a note about the ALS settings. So the lab is willing to help with the logistics. And then it looks like the same labs are charging quite a bit for a panel. Absolutely. Any other questions? Thank you so much. This is great. These are great questions.
Are there questions? I have a question, Lauren. If the urine PCR is not FDA approved and our nursing facilities are using it to help diagnose UTIs and make treatment decisions, does that affect how we're looked at it when it comes time for survey and evaluation for being compliant with regulations?
That's a great question. I am not sure about the regulatory piece. Honestly, I think one of the things as well, it's not FDA approved. Many of them are CLIA approved or lab approved, right? So I just mentioned the FDA approval because then you would probably see more standardization, you know, and things like that and incorporation into guidelines. But as far as the regulatory piece, I don't think I can speak to that, unfortunately. I'm not sure.
Sure. No,
It's a good question.
I think that we're for sure seeing the labs making this test accessible to both nursing facilities and assisted living facilities. I'm really glad that you brought this up and were able to explain what you're seeing.
Yeah, and thank you, Sing, for helping out with examples. Those were very illuminating.
I thought maybe someone might ask, you asked us to utilize the lobe criteria and urinary symptoms. And of course, we hear so much about McGear criteria as well. Can you comment on the difference between those?
Yeah, absolutely. So I think in this setting, when we're really focused on infection and starting antibiotics, we're really focused on those local urinary symptoms. For McGear is great for surveillance, and we use it for retrospective chart review. But for prospective initiating antibiotics, the lobe criteria would be recommended. Yep.
Oh. In chat, I don't know if you're still on. I think you are. If you have any comments about using a non-FDA approved test for, assessing infections, we'd love to hear any of your thoughts about that too.
Okay, yes, I'm still here.
Oh, thanks.
To my knowledge, we cannot use a test that is not approved.
It sounds like it's CLIA approved, but not FDA approved. I don't know if we have any stipulations on that level of approval.
All right, let me do some follow-up and I can get back to you.
Sure, thank you. If anyone has any questions, please feel free to shoot them over to me and I can make sure Lauren gets them. And we will certainly circulate your slides if you're okay with that.
Sure.
People are very interested. So yeah, thank you everyone for joining us today. We're so happy to have this discussion and have all of our great speakers. I will send all the slides out. We invite you all to join us at our upcoming CMDA events, including at the next monthly meeting, March 7th, the AMDA annual conference in Tampa, Florida, with a special Colorado reception, our monthly meeting in April, and of course, our CMDA annual conference. So please get yourself on those calendars and register today. Thank you very much for being here today. Bye-bye.
Thanks, everyone.